you for joining us. My name is Barry Erickson, and I'm Community Engagement Coordinator here at Wheaton Public Library. Tonight, in honor of Mental Health Awareness Month, we are proud to host this program on depression treatment alternatives. Dr. Sanjoy Roy has worked for over 15 years as a manual physical therapist in various areas, ranging from hospital to private outpatient practice settings. He has been a staff clinician, director, clinical instructor, guest lecturer, expert consultant, entrepreneur, and has dedicated his life to bringing quality care to his patients. He is especially skilled in manual therapy, joint mobilization techniques, dry needling, and has a keen interest in treatments of pain management and fibromyalgia. He is currently co-founder of Albatross Physical Therapy and Wellness and Albatross TMS and Pain Management. So thank you so much for being with us tonight, Dr. Roy.
Thank you for having me, Barry. And I'd like to thank Wheaton Public Libraries for allowing this opportunity for us to be able to share some of the knowledge that we have. This workshop, this depression workshop, is intended for those people who are interested in learning more about some alternatives to their already treatments that they're receiving for depression. And we're very excited to share some of these alternatives with them. There is also a special guest with us today. I'm very pleased to share the screen with Dr. Iman or Mahmoud Hussain. He is a psychiatrist, and he's going to be talking to us about TMS, which is a promising treatment for depression. And it's FDA cleared, and it is also covered by insurance. And I think I'm going to let Dr. Hussain talk a lot more about it. In addition to that, I'm also very pleased to say that we are talking about depression in an open forum. And this is one thing that we probably couldn't be talking about maybe many years ago, just because it's such a stigmatized illness. And so the fact that we are able to talk about this in an open forum is quite reassuring and encouraging for all of us. I also must make this a point that whatever we share with you today, whatever treatment options or any sort of suggestions that we offer today should be consulted by your doctor or even Dr. Hussain after the workshop, so that everybody is safe. And lastly, depression is a vast topic. So what I'm going to try and do is keep things very simple and easy to understand. And I hope that all of you get some value out of what we show to you today. Okay. Now I'm going to start off by, let me see here. Just telling you a little bit about myself. I am a physical therapist. I've been practicing physical therapy for over 15 years. I really am a Wheaton resident, and due to the insistence of my wife, she said, "Hey, Sanjoy, what are you doing? Why are you practicing physical therapy everywhere else but your own community?" And she encouraged me to open up my own practice. So I started Albatross Physical Therapy and Wellness in 2018, and I've been practicing ever since and helping out our community by treating acute and chronic pain. I also started Albatross TMS and Pain Management due to the emerging and more wide problem that we're having with depression. So I think that I'm very optimistic that we'll be able to help more people suffering from depression through the TMS and pain management clinic that we have. I also want to say that I have, excuse me, sorry about that. I also want to move on and talk to you about Dr. Hussain. He is a double board certified psychiatrist and is in both adult and child psychiatry. He is a previous assistant professor of psychiatry at Baylor College, and he is also a medical director of TMS and pain management here in Wheaton. He will be talking to you again, like I said, about more effective treatments using TMS, and I'll let him do that in a few slides. Now, what is depression? Depression, of course, is a major major depressive disorder. It is a serious medical illness. Hold on a second here. That negatively affects how you feel and the way you think or how you act. Depression causes feelings of sadness and or loss of interest in activities you once enjoyed. It can lead to a variety of emotional and physical problems and can lead to decrease in ability to function at work and at home. It is a leading cause of disability worldwide. Over 300 million people suffer from depression, and I think that is actually a very conservative number. I think that number is a little bit more than that. It actually got worse after COVID-19. The percentage of people suffering from depression prior to COVID-19, prior to the pandemic, was only 7%, and it has actually increased to about 27 to 30% after that, after our pandemic. And it also has it actually overlaps with anxiety as well. So we know that people with depression actually have a 40% overlap with anxiety and vice versa. About 1 in 5 people, or about 20% of people, will have depression in their lifetime, and about 10% of those people will also suffer from depression in about a year. So these are some really stark numbers. So what is depression exactly? And most of you might know this, but it's not normal sadness. It is very different from sadness because sadness is transient. It doesn't stick around for too long. Usually it lasts less than 2 weeks, and depression actually lasts more than 2 weeks. And sadness is caused by a unique event and a major emotional event, like maybe loss of a loved one, but depression doesn't have that event that causes it. It is, and unlike sadness, it's debilitating, and it doesn't have a direct reason, like I mentioned. It has, and you can feel feelings of low mood that arise without reason. Also, it can lead to isolation. Now, I don't know if you all have seen the new report that was released by the Surgeon General from the Health and Human Services. The report showed that there's an actual epidemic in the United States of loneliness. And what he says in that report is that loneliness actually causes an increase of stroke, heart disease, Alzheimer's disease, as well as dementia. It can actually lead to an increase in death. Loneliness actually increases depression by double than people that are not lonely. So there's definitely an epidemic in the United States of loneliness, which can lead to depression. Of course, depression can also lead to suicide, ideation, and or death, okay? And it can also lead to things like unexplainable aches and pains, which is a diagnosis of what we call fibromyalgia. And I will talk a little bit more about fibromyalgia as we move on. But one hallmark sign of depression is hopelessness and worthlessness. So if people are just sad, they don't have those feelings of hopelessness or worthlessness as people with depression do. So what causes depression? Well, depression has 3 major reasons, and biochemical imbalances are one of those reasons, and that's from medication. So if people are taking medication, for example, off the top of my head, I think Accutane is one of them. Well, Accutane has been a medication that's used by adolescents, teenagers, and young adults for acne, and there's a serious side effects that are associated with Accutane, such as depression. Also, patients that are postpartum moms that have hormonal imbalances can also have depression. Second influence is environmental influences like physical and emotional trauma. Patients that have had sexual trauma, physical trauma, and verbal abuse can also exhibit depression. Genetic influences. There is a Stanford study that has been done that suggests that heritability can contribute to depression, and about 40 to 50% of people that have depression probably have it through some genetic trait from their father, mother, grandfather, or grandmother. But fortunately, it is a treatable illness. And the traditional forms of treatment are pharmacological medication, SSRIs, and or other medications in that same category. But they have numerous side effects associated with that. And of course, there's psychotherapy, which is talk therapy, and it seems to have only a 60% efficacy in treating depression. So we're here today to talk about some other ways to manage your depression. So you might be wondering, why is a physical therapist talking about depression? So as a physical therapist, I've been working about 20 years treating acute and chronic pain. And during that time, I've been able to come across patients with chronic pain with an underlying condition called fibromyalgia. Does anybody know what fibromyalgia is? I know I can't see much here, but fibromyalgia is characterized by a global somatic pain. And it's a pain that's really doesn't have a defined cause. So in the past, when people had this global somatic pain and they went to their doctor to ask for a diagnosis or some sort of treatment for it, doctors really didn't know how to treat it effectively. And they often dismissed these patients and disregarded them, thinking that they were disingenuous about their symptoms. But as we learned more about fibromyalgia, we figured out that there was a strong correlation between fibromyalgia and trauma, especially emotional and physical trauma in the past. Now, if we think about this for a moment, physical and emotional trauma is also related to the condition of depression. So then we found out that there might be a strong link or correlation between fibromyalgia and depression. And new evidence also shows that depression and fibromyalgia may be bidirectional. So if you have fibromyalgia, you may have underlying depression. And if you have depression, there's probably some fibromyalgia, global muscle pain that can manifest from it. So my curiosity pursued, and knowing that there's chronic pain that was linked to related mood and behavior changes. So if you had mood and behavior changes or depression, it would be linked to chronic muscle pain or global muscle pain. I turned to figure out how I could treat patients with global muscle pain and also treat depression at the same time. And my studies, I found out there's an area of the brain that actually is related to both fibromyalgia and depression, and that's the dorsolateral prefrontal cortex. The dorsolateral prefrontal cortex in humans is the most elaborate part of the brain. In all of the animal kingdom, humans have the most complex dorsolateral prefrontal cortex. And it is the area of the brain that is significant for control of cognitive behavior. That means switching between tasks. I don't know if you guys know what the Stroop test is, and I'll explain that a little bit here. But if there's a board or somebody writes the letter red on it, but it's in the color green, okay, and you switched up this sign with other signs of similar nature, the people with lesions or impaired dorsolateral prefrontal cortex would not be able to say the color quickly enough. Okay, so we find that with the prefrontal cortex. And it's also the area of the brain that's responsible for goal-directed function, which is executive function, in other words, or attainment of goals. For example, knowing that you're on a diet, you're not going to reach for the chocolate cake because you're on a diet and you want to lose weight. Okay. It is also shown to be most consistently impaired region in depression, which we'll talk about in more detail in the coming slides. It also developmentally matures between the ages of 20 to 30 years old. Now, how many of you people have seen a teenager that races to a residential street, knowing the full risks and consequences involved? Well, the reason why they're doing that is because possibly their dorsolateral prefrontal cortex isn't fully developed. Another example is how many of you have had a tattoo when you were younger, maybe in your teens, even though your parents told you not to do it, you went ahead and did it, and now years later you regret it. Was possibly because your dorsolateral prefrontal cortex wasn't developed as well yet. And so what you did was you kind of resorted to doing activities that are more riskier and even less moral in decision making. And so what you intended to do was maximize your immediate personal gain or gratification. What we see later on in life is that people with more mature dorsolateral prefrontal cortex after the ages of 20 to 30 years old tend to make more equitable decisions or more moral decision making. Okay, so let's go back to the previous slide. Now, the previous slide also shows a PET scan at the right side. Now, if you look at those two images there, the left side shows the depressed state of the brain, and the right side shows the non-depressed state of the brain. The depressed side shows that there's less activity there, and the non-depressed side shows that there's more activity there. Now, this can be attributed to more oxygenated blood into the more active area in the non-depressed state. So what this shows is that activation of the brain is dependent on oxygenated blood flow, as opposed to the depressed state, which is underactive and less oxygenated blood is in that brain, okay? So what this showed was that so low activity or lesions to the dorsolateral prefrontal cortex shows greater expression of depression symptoms and possible low motivation to do things for yourself or for others. So as a PT, I stopped to wonder to see if, because oxygenated blood to the brain is responsible for greater activity, could exercise be used to improve oxygenated blood to that area of the brain, the dorsolateral prefrontal cortex, and improve activation? And the answer is yes. So I took 3 studies and I looked at them. And the first study shows that exercise actually improves oxygenated blood to the dorsolateral prefrontal cortex and activates the brain in that area more strongly. And so those people that have activation of dorsolateral prefrontal cortex are able to sustain unpleasant feelings for a longer duration of time, or did not demonstrate symptoms of depression as quickly. On the second study, I looked at activity of the dorsolateral prefrontal cortex and showed that with oxygenation of that part of the brain, it corresponded to improved executive performance meaning that those people were able to resist eating that chocolate cake because of going on a diet, okay, so to speak. And the third one, we looked at oxygenation of the brain and how it improved activity of the dorsolateral prefrontal cortex. And it showed that exercise actually increased activity of the dorsolateral prefrontal cortex more than any other parts of the brain. And it also improved improved low levels of mood. So then, now that we know that exercise helped to improve activity of dorsolateral prefrontal cortex, does exercise also help to conclusively prove that it helps to decrease depression? Well, there's a study that was released this year in 2023, and it's called the Heisel study, and it was the talk of the town in the physical therapy world. It took 41 studies and over 2,200 completed participants, and found that exercise did have a moderate to large effect on depressive symptoms. The conclusion here is that exercise does have a positive effect on treating depression, and in my opinion, actually is extremely important in treating depressive symptoms. Furthermore, studies by Chung and Ahmad also show that there's a statistical significant decrease in depression with exercise. Now, you might be wondering, how does exercise actually work? Well, if you increase exercise, you're increasing oxygenated blood to that area of the brain, and you're also improving certain chemicals such as neurotransmitters to that part of the brain. The two of the major chemicals that I looked at were dopamine and serotonin. Dopamine is, of course, the feel-good or reward chemical. It plays a key role in creating that winning feeling the feeling you get when you achieve a goal or have a new experience. There's research done into the motivations behind gambling, excessive video games, and social media that showed that there's an increase in dopamine levels when people participate in these types of activities. And I look at my father-in-law when sometimes, and I see that he's so engaged with his cell phone, and it doesn't matter where we are, what we're doing, he's always on his cell phone looking at his TikTok videos. And it's because he's constantly getting these dopamine hits every time he's seeing these new videos on TikTok, and he can't get away from it. So that's a dopamine hit there. So dopamine also plays a key role in various bodily functions, including movement, sleep, mood regulation, learning, memory, and attention. Another neurotransmitter or chemical that's in the dorsolateral prefrontal cortex predominantly is serotonin. It has a key role in controlling mood, appetite, sleep, and even behavioral flexibility. Okay, now what you want to remember here is dopamine is the motivation chemical as well. So if there's low dopamine, there's low motivation. And if there's low serotonin, there's low mood. And this is a very general and simple take on it, but those are the key takeaways here. So you might be wondering, well, Sanjoy, you spoke about exercise and how it positively affects the dorsolateral prefrontal cortex because it increases activity. And you also said that exercises helps to decrease depression as a result of that activity to the dorsolateral prefrontal cortex. Say that 3 times. Now, what type of exercises should you do? Well, the exercises that I found in majority of the studies that were done were aerobic exercises. Now, you might be wondering what aerobic exercises are. What they are is basically steady state exercises that use oxygen to produce energy by using energy sources such as carbohydrates and fat. So running, cycling, swimming are really good low intensity, steady state exercises that can be done to improve depressive states. Now, you might be wondering now is what intensity should I do these exercises at? Well, one way to figure that out is to take your target heart rate. Now, how do you calculate your target heart rate? Well, you take the number 220 and you minus that by your age. You can use other methods, but this is the most simple way. And then once you get that number, you multiply it by 60%. And then that's your target heart rate that you want to achieve when you're doing these type of aerobic exercises. And the studies show that if you did this 3 times a week for about 30 to 45 minutes, this will help to decrease your depressive symptoms and also help to improve your sleep. Okay, so exercise in summary here helps to increase dorsolateral prefrontal cortex activity. It helps to improve neurotransmitter circulation throughout that area, and thereby improving mood and improving motivation. And it also, as a result, may help to decrease depression or major depressive symptoms. There's also another aspect of exercise that I wanted to talk about. There's this professor named Dr. Mark Snyder. He suggests that behavioral activation is a way to modulate depression. And he says the source of the problem is behavioral avoidance. So what behavioral avoidance really is if a patient is depressed and has low mood or low motivation, they don't generally want to do pleasurable activities or go to parties or go to the gym. And as a result of that, they eventually are not invited to those parties or feel justification not going to the gym so that they could have a nap. Okay. And guess what? They further spiral into a negative feedback loop because there's no opportunity for them to have positive reinforcement, because there's no pleasure or from socializing. There's no accomplishment that they're getting from going to the gym and exercising. And this further leads to isolation and deeper depressed states. So what he says is that the goal of behavioral activation is to really master your pleasure activities. So what he says is to really kind of keep a log of everything you do during the day and write down every time you feel sad, okay? Or write down every time when you have a negative thought. And when you do have that negative thought, go do something. Go do something pleasurable. Meet your friends, go to the gym, exercise. And by doing so, what you find is that your negative thoughts, thoughts of depression actually don't arise. And so it's important to do pleasurable activities and especially exercise when you're having these negative thoughts. I'm going to move forward all the way to conclusion here. So overall, what the message here is that exercise helps to improve dorsolateral prefrontal cortex activation, and by doing so helps to decrease depression. Although there's more studies that need to be done, I think the consensus here is that exercise helps in general, right? Not only by improving depressive states by simply the act of exercise, but also from getting up and doing something when you're feeling down, okay? And then, of course, exercise also helps in other ways in terms of improving cardiovascular health and also improving musculoskeletal function, and that's what I do as a physical therapist. We are very fortunate that we're starting to understand that depression is a illness that can be treated very well. It is gradually becoming destigmatized, and we're really trying to have a better understanding as to how to treat it without only having to rely on medication and talk therapy for treatment. And going back to Vivek Murthy, the general surgeon again, about the epidemic of loneliness leading to depression, an easy thing we can all do right now is just be present and listen to people and our loved ones. And by staying all connected to one another, this is one thing we can really do to help decrease major depressive disorders and depression. All right, from here, I'm going to pass the baton off to Dr. Hussein. But before I do that, I just want to share a quick story. As I treat patients for chronic pain and acute pain, I often come across patients that like to share stories with me. Well, I'm here sharing a story with you. I had a patient who had shoulder pain and was treating her on a table doing manual therapy. And she began to tell me about her husband. Now, her husband has a history of depression for many, many years. And she asked me this one question. She said, Sanjoy, have you heard of transcranial magnetic stimulation? Now, I've been in this industry for a very long time, and I've heard of every gadget, and gimmick available to mankind. And I was like, oh boy, here we go. This is another gadget that somebody else is going to tell me about. And let me hear what it's all about. So she kept saying that transcranial magnetic stimulation has helped her husband so significantly that he was seen just getting up and doing things in his backyard without ever having been told. And prior to this treatment, he didn't even want to get off his couch. He was more happy. He was engaging in conversation more. And one thing that really piqued my interest was that his balance even got better. And as a physical therapist, when people talk about motor skills, that's the first thing I'm really interested about. So she said that transcranial magnetic stimulation actually helped him go up and down the stairs more easily. So this piqued my interest more, and I dived a little bit more into understanding what TMS was all about. And I learned that it had incredible efficacy. It has a great remission rate. It is FDA approved. It got approved in 2008. And it's also covered by insurance. And I found that to be incredible, especially for people that are suffering from depression. Knowing depression is such a huge problem in our community, I decided to talk to Dr. Hussein about it, and we both discussed it would be a great way to help our community. So now I'm going to pass it off to Dr. Hussein to talk a little bit more about TMS and how it can help patients with depression.
Thanks, Dr. Roy. Thanks, Barry, Wheaton Library, for having me. And so my set of slides are actually on Dr. Roy's computer, so I'll be prompting him to go to the next slide.
There we go. You good?
Yeah, okay. Yeah, just a little bit about me. Dr. Roy had already mentioned, but I am a board certified psychiatrist in both adult and child and adolescent psychiatry. I've been practicing probably about going on 6 years now, and interventional psychiatry is this newer field where we're kind of going away from the basic talk therapy and medication management that most people believe is how we treat these psychiatric conditions. So TMS is one of these newer cutting edge technologies that falls into this field of interventional psychiatry. But of course, for the most part, I'll be focusing on TMS. Okay, next slide. All right, so some of this is a little bit of a reiteration of what Dr. Roy had already mentioned. So what is depression? Of course, like he stated, depression isn't just it's not just feeling sad. It's basically when the sadness has taken the next step and that is now influencing other aspects of your life. And so the way we typically diagnose depression is when we start to see a lot of these other behavioral changes. So mood changes, yes, like I said, sadness, but sadness is, sometimes hard to acknowledge or even be aware of. For a lot of people, it may come off as irritability. Or apathy, just feeling like you don't care. And then if someone asks them, are they sad? Of course they'll say, no, I'm not sad, I just don't care. But again, a lot of these other moods can, in a way, be a type of sadness. Sleep and appetite changes are actually really common, whether that's sleeping too much or sleeping too little, and as well as eating too much or eating too little. Concentration difficulties are very common. And then this inability to really feel pleasure, just not really enjoying some of the things that you used to. A term we use is anhedonia for that. Low energy is also really common, just not having the motivation to get out of bed, just don't feel like getting things done. And then, of course, suicidal thinking, like just passive thoughts of dying, wishing you weren't alive, wishing you didn't exist, or even taking the next step to where you're kind of actively thinking of a way where you might want to end your life. So all of these are what we call sort of symptoms of depression. And so when we get into really talking about depression, we're saying that you're having, some sort of changes in multiple areas and not just that mood change. Next slide. So yeah, depression then is behavioral changes. And so what can this result in? Like Dr. Roy also mentioned, isolating yourself, not getting engaged in activities, like not going out to the party that, your friends or whoever asked you to come to. If you're not playing with your children, just not doing things anymore. Like I mentioned, sleeping too much or too little, of course, that can affect your weight. And then just not having any energy or motivation. Concentration difficulties, of course, this can affect you at work, affect your performance there. Feeling distracted, irritable, apathetic, like I stated. And then I think the most important thing when it comes to actually diagnosing someone with depression is that there's this functional decline from the baseline, that person's baseline. So whatever was where they believed or what we would say was normal for them, now we're at a state that is less than that. All right, next slide. So before we get into TMS, there's a couple of, I guess, concepts or definitions that I just wanted to mention, just because I'll be using these a little bit more now. So neurons, okay. Neurons are the basic cell that's in the brain, and neurons send and receive signals and they communicate with each other. So our brain has trillions of neurons. It's just a huge network. And again, each of those cells are neurons. Electricity. So our bodies run on electricity. That's a concept that a lot of living organisms, most living organisms run on electricity. That's why when our heart stops beating, you actually electrocute the heart to get it beating again. The heart is beating every second of your life because of that electricity. This is why when we're, if we're outside in the middle of a field in a lightning storm, we're at risk of getting struck by lightning because our bodies are conducting rods. So our brain similarly runs on electricity. Our muscle cells, most of our cells in our body are basically using this electrical potential, and that is how the cells are functioning. Magnetism. So magnets can create electrical currents. That's just magnetic energy. It just converts into electrical energy. It's just a property that magnets have. Neurotransmitters. Dr. Ed also mentioned this as a term, but the way I like to think of it is these are the chemicals or the signals that actually do the communicating. So we said neurons are communicating with each other. Well, neurotransmitters are the chemicals that they're sending out to the next neuron. And therefore, that's how they're communicating with one another. And then the term neuroplasticity. So yeah, the brain actually doesn't fully develop until around mid-20s. Of course, it's developing at a much higher rate in early childhood, but it is still developing somewhat early, mid, even late 20s. Now, the term neuroplasticity means the ability for the brain to undergo changes, or the capacity it has to undergo changes. If we say that you're maturing, your brain is maturing until mid 20s, late 20s, then at 35, is it maturing anymore? Or is it really going to change anymore? So usually, no. I mean, yes, you can form new connections based on new memories, but overall, significant changes in the brain don't really take place anymore. So the term neuroplasticity then is where we're inducing or getting the brain to make changes. Next slide. So treatment options for depression. And again, the first one is the one Dr. Roy had spent a good amount of time talking about, especially the lifestyle changes. But psychotherapy and lifestyle changes, yes, they work. They do work. Not only do they work, but they do induce physical changes in the brain. Even at the age of 40 or 50, you can make physical changes in the brain if you're able to implement lifestyle changes that become habitual, where it's not something that, you've done for a week. It's a routine at that point. Psychotherapy or talk therapy, where you're, working with a therapist to train yourself to think of something in a different way. All of these things do make physical changes in the brain, and you can use that to treat your depression. But caveat is that it does take time. It won't change overnight. It's not going to change, usually even a month or so. 2 months isn't enough time. You need time and active involvement. And so the problem there is that sometimes it is really difficult to remain motivated. If you're talking about someone who is struggling with depression, they're already lacking the motivation. They're feeling hopeless. So time isn't something that they feel that they have a lot of. Number two, medications. Again, medications have been around for a really long time. They do work. And the benefit is that they actually can work fairly quickly, but they're not actually inducing any physical changes to the brain. What are they doing? They're more or less modifying the chemicals or the neurotransmitters that we were talking about, and hoping that the neurons are going to do what they do and fire, send signals, receive signals. But we're just changing sort of the mix that's in the brain with the medications. And of course, we have some problems with that, which would be potential for drug dependence or addiction, as well as experiencing side effects. And the third that we have that I've listed here is TMS, or transcranial magnetic stimulation. And that's what I'm going to focus on for most of the remainder of the slides. But in comparison to therapy and medications, what we have is that TMS can actually produce those physical changes to the brain, the way that talk therapy and lifestyle changes can actually produce physical changes. TMS can do that as well. Not only that, but it also works quicker. It may not, where therapy may take a year of therapy to get you to feel less depressed, or, to be at a state where we've, say that you've been in remission from depression. TMS can do it in a month, 2 months, 3 months. So we have the benefit of making physical changes and working quicker. In addition to that, TMS actually makes therapy and medications work more effectively. So because now that you have gotten the brain to be more active and sort of firing the way it should, therapy has a bigger influence, and medications themselves, because again, you're modifying the chemicals in the brain, you're able to get the TMS gets the neurons firing better, and then medications then work better. So it kind of helps out in a lot of different regards. And then the other, the part that I love the best is there are usually no side effects. Next slide. So how does TMS work? Okay, so Dr. Roy had mentioned the dorsolateral prefrontal cortex. So dorsolateral prefrontal cortex, or DLPFC, that you saw is, he also uses this abbreviation. It is responsible for a lot of things. The left side of the DLPFC is what we've seen where a lot of our emotional regulation comes from. So knowing that, as let's take that one concept. So we have this front left side of the brain that is where a lot of our mood regulation is. Okay. And then of course I had mentioned magnets. Magnets, now we know they're harmless. There's usually no side effects to magnets. And the benefit is that they can create electrical currents. Again, electricity. So we're saying then magnets can convert into electrical, or magnetic energy can convert into electrical energy. And these electrical currents then can influence neuronal activity in the brain. Again, going back to the concept that our brain uses electricity. So we're saying we use magnets basically to create electricity, which then can influence the neurons in the brain. And then on the right side, neurotransmitters. Again, neurotransmitters being the chemicals that our brain is using to send, and that our brain is basically using to communicate. The neurons are usually using to communicate. Now, all of a sudden, because we're influencing the neurons' activity, we're getting the chemicals to work more effectively. So the neuron is now sending the signal better and receiving signals from other neurons better. Number 5, the term again, neuroplasticity, where we're making the brain more pliable or able to accept change. Basically, now that we're improving this activity of the neurons in the brain, we're inducing neuroplasticity, right? So we're, again, focusing on the front left side of the brain, using magnets to create electricity to improve the neurons' activity, which then are sending signals more effectively and communicating better, which then is inducing changes. Basically, the brain is now changing. And so the brain then is able to respond more accurately, or respond better, if you want to say it that way. And of course, again, number 6, the summary here is then we now have physical changes. The resynchronized brain is now working better the way it was basically designed to work before the depression, or whatever the mental illness has before it's kind of set in. Next slide. So this is just a sort of generic picture of what this magnet looks like. And what you see here is a patient just sitting there. He's smiling. I would say most of our patients, when they have going through TMS, they're smiling because it doesn't really hurt. Usually you're kind of engaged in a conversation with them. This figure 8 coil that you see on her head, that's actually what the magnet is. So it's 2 coils side by side. And when you put 2 magnetic coils together, you're actually creating an electrical current that is moving in a direction that's, I guess what we would say is parallel to the 2 magnets. So this, again, magnetic energy is creating this electrical current inside the brain, and that's how we're inducing these changes in the neurons. And I know this term transcranial magnetic stimulation sounds long, but I just wanted to break that down. That trans literally means through. Cranium is the skull. So we're talking through the skull. Magnetic obviously using magnets and stimulation, which for when we're talking about treating depression, what we're saying is that we're stimulating the neuron. So we're activating the neuron. So transcranial magnetic stimulation is just the concept of using magnets to go through the skull and influence then the neurons. Next slide. This is just another picture that I found where I think it shows where the two magnets are side by side. And because they're side by side, you have a way to sort of control which direction this electrical current is being generated. And so that again, magnets harmless, pass right through us. And it's because they can pass right through the skull, then they can create the electrical current in the neurons. Yeah, next slide. Dr. Roy had used this slide also, but this is just, again, just sort of an illustration where it's trying to depict where a depressed brain, if we, did a PET scan to show where there is activity, you see that there are a lot of dark places showing low activity. And then after TMS, you see a lot of areas that are lit up. So earlier, I just said that we're talking about the front left side of the brain. And actually, if you paid attention to the picture earlier, I think it looks like they're using the right side of the brain. The right side of the brain, left side of the brain, regardless, I think, they could be trying to treat something else. But overall, with this picture, I think is the most important key here is that even if it is the left side of the brain that we say is in charge of or responsible for emotions, it's not that our brain is sort of like certain, we have a block here and a block there and a block here, and they don't talk to each other. They all talk to each other. And that's why depression, again, is, affecting so many aspects of our life. So in a depressed patient, you are going to see almost what we would call global. Globally, it's hypoactive, or globally, there's not a lot of activity going on. And after TMS, even after TMS focused on the front left side, you see activity all throughout the brain because, again, neurons are talking and they are, communicating with other parts of the brain. Next slide. So this is, something where I thought if anyone's interested, where we're, how are we saying this TMS is really working? I just wanted to break it down maybe one step further because I didn't want it to sound like this is some sort of magic or mumbo jumbo. We say you put a magnet to your head and then all of a sudden depression is cured. But there is some science here, and the way we actually sort of go through this treatment is that step one is that we try to determine what we call a motor threshold. What does this mean? Well, everyone has a minimum amount of magnetic energy required that will get neurons to work or to fire. So I can have a certain number that I need. Dr. Roy can have a certain number. Barry can have a certain number. And what is that number based on? It's based on your entire body chemistry. How much coffee you drink in a day, what you eat, how much you sleep, medications you might take, your body fat percentage, muscle mass, bone density, conduction. There's a lot of factors at play, but basically we can't say that Dr. Roy and I both would have the same magnetic energy required to turn on a neuron. So we have to determine what that number is. So we determine that. And again, we're looking for the minimum amount of magnetic energy. So now that number two, once we find that, what we do is we actually then shift over to the left dorsolateral prefrontal cortex. And then we use that same level of energy and we apply it to that part of the brain. And we do this by sending what we call trains or groups of magnetic pulses. So it sounds like a series of clicks. And then, so again, we figured out what was the number that was required for this unique individual. And then we shift over to the front left side of the brain and then apply that number to get the dorsolateral prefrontal cortex to fire. And then number three, we continue TMS sessions. Now, TMS is designed to be Well, we want to make it as convenient as possible. So the sessions are very short, 20-minute sessions, but we do like to go through them up to 36 days spread over 8 weeks. Why? Because more magnetic pulses over time results in a better response. If we were to go to the gym and worked out for 18 hours straight versus going to the gym every day for 1 hour for 18 days, I think we would have better endurance, muscle mass, stamina. Overall, it would be more beneficial for us to go once a day for 18 days, even if it's an hour a day, as opposed to doing it all at once. Similarly with TMS, we can't turn on everything in one day. So we designed the treatment so that you get a little bit of TMS every day for a span of up to 8 weeks. And then number 4 on the left side, again, neuroplasticity. We're saying the neurons are then becoming more active, communicating more effectively, and then it's reinforcing their connections. That's another thing. If neurons communicate with one another consistently, that connection then becomes stronger. So if we're trying to decrease depressive symptoms, then basically we are reinforcing these connections. And ideally, and this again, one of the better things about TMS, we're sustaining this new active state indefinitely. Ideally, TMS is going to put you at a place where you don't have to go back to TMS again. We are trying to create connections between neurons that are stronger and that stay stronger. Next slide. TMS, this is a statistic from one of the studies where it says 81.8% response. Really quick, the way we define response rate, or actually it's at the top here, it says 50% improvement in depression symptoms. So in general, when it comes to mental health, if we say someone responds to something, we're saying that they have a 50% reduction in symptoms. So if they were an 8 out of 10, if you want to call it, in depression, then to say that they responded to something means they would have to go down to at least a 4 out of 10. So TMS, over the years, it has gotten better because the technology has gotten better, but we are at a place where we can see about 70 to 80% of people will respond to TMS. That's saying 70 to 80% of people going through TMS will have at least a 50% improvement in their symptoms. Not only that, up to a third of the total group of people will be in remission stating that they no longer have depression. We've cured their depression. So first of all, we're saying up to 80% have a 50% reduction. And then the third will be as far as saying they no longer have depression. And even out of that, when we say up to 80%, well, what about the other 20%? Well, the other 20% will tell you that they're also doing better, but it just might not be the 50% number. They may have had a 20% improvement or a 30% improvement, but it's almost consistently that every study you look at, that everyone feels some benefit after going through TMS. And the number there comparing to antidepressants is taken from a very famous hallmark study in the psychiatric world called the STAR-D, where they were looking at how effective are medications, and how many times does it take to get that sort of response. And usually the first time around, we're looking at about a 49%. Well, actually, this is averaging, I believe, the first 2 rounds, but it's not a great number. 49%, that's kind of hit or miss. And then usually if you're kind of just focused on medications, we try another medication and, kind of go through that. So medications, we just have a lot of uncertainty, and everyone is different when it comes to their response to medications. Next slide. So this is a slide I created just to kind of list what are the most common questions I get from patients when I talk to them about TMS. Number 1, most common is side effects. Honestly, permanently, there are no side effects that have been reported. And that's to say that we're using a technology to treat depression that does not have any side effects, I think that speaks a lot. But while undergoing TMS, it is possible to have some temporary headaches, scalp, face, eyelid, or jaw discomfort. And that's because we are using magnetic energy to wake up the neurons. So while it's passing through the superficial skin on our face, on our scalp, it can activate the neurons, or sorry, the cells at that part as well. And so you can feel like it's pulling sometimes, but usually this is something we can help by positioning the magnet differently or reducing the intensity. So again, though, it's temporary. And even when it comes to headaches, it's something that most people feel the headaches get better as they come in for TMS after a couple of weeks. Their body kind of gets acclimated to it. And even further is that TMS can also improve migraines. Specifically, the way we treat for depression, maybe not so much, but TMS itself, most people feel that if they have a history of migraines after going through TMS, that their migraine frequency and intensity does decrease. So that's another benefit there. How many days? Okay, again, I mentioned this 20-minute sessions that we try to do over 36 days, spread over 8 weeks. And we all went over why we want to do it once a day, as opposed to all of it at once. How long will it last? Now, this is individual, but ideally, again, TMS was designed to continue to last indefinitely so that you don't have to come back and do TMS again. Now you can, insurance companies do kind of want to know why, and they might, not like it if it's consistently something that you're going after, but most people don't feel that they need to come back for TMS. What about medications? Do I keep taking these meds or what? So usually the way we like to go through TMS is if you're on medications, keep those medications and continue that same regimen. And then after TMS, see how you're doing. So usually we don't like doses to be changed or new medications to be added or medications to be taken off, at least while you're going through TMS. Because again, I had mentioned earlier, TMS actually helps medications work better, work more effectively. So if we can go through a full treatment course of TMS, it limits the variables at play. And so then after we're done, we can see, well, do we really need all of these meds? Do we really need to be at these doses? Can we decrease some of these doses? What else can TMS do? So it is FDA approved for major depressive disorder. It has FDA approval for OCD, for, I believe, certain of the TMS devices. Smoking addiction is another one that it's FDA approved for. But the technology itself has been around for a while, and there are other conditions that are treated off-label. So addiction is one, bipolar, especially the depression part of bipolar, anxiety, cognition, so sort of the enhancement and thinking sharper and clearer, PTSD. So there are ways where TMS can help reduce sort of the hyperarousal you get in PTSD when there's a trauma that triggers you, or sorry, a flashback or memory of a trauma that triggers you. And then it's also used in treating chronic pain, and like I had mentioned, migraines as well. Okay, who can't get TMS? So specifically, mania, psychosis, and mania and psychosis are going to be what we say in the psychiatric world, specifically having a manic episode or feeling, and psychosis would be that break from reality. So people who have schizophrenia, for example. So manic and psychotic episodes are the two places where we don't really get into TMS because there probably won't be a lot of benefit there. Active substance use or active drug use is another one. If they're, drinking heavily or using cocaine or some sort of substance that can really mess with the body chemistry, we don't. And epilepsy is another one, because this is special because we had said earlier, we try to we're trying to increase the activity in the brain. And so people who have epilepsy, as in someone who has diagnosis of having seizures consistently throughout their life, if they are not under control, then they can have more seizures, unfortunately, if you were to kind of start activating that brain. Next slide. And this is another question I get where they say, oh, you're talking about shock therapy, right? So no, not shock therapy. And I wanted to differentiate that because I also feel that with this concept of using electricity, it kind of gets lost in translation and people think of what they refer to as shock therapy. So shock therapy, or actually medically what we call electroconvulsive therapy, or ECT, it is the idea of using basically electrical currents to induce a seizure while someone is under anesthesia. And why do we do that? Well, again, going back to the concept, the brain runs on electricity. The idea is if we can hit the reset button in the brain, then maybe we can start over, start fresh. And it does work. It is, though, reserved for more of the serious conditions, people who are actively suicidal or catatonic, where we say catatonic as in they just kind of lay there, won't eat a bite of food, would rather let their body sort of wither away, common in the elderly population. So in those situations where there's almost no other way to get them better, ECT can be used. Now, there are several side effects to that because you are inducing a seizure under anesthesia. So you can imagine there's memory loss and people feel like their personality changes. So there's several sort of side effects there. TMS is different in the sense that we are not trying to sort of zap the whole brain. We use magnets to stimulate a certain region of the brain. And by focusing on that, we're trying to improve overall sort of the symptoms that you're experiencing. And side effects, none. No need for anesthesia. You do it outpatient. You don't need to be in the hospital. No pain. So a very different take on that treatment. Next slide. And this, I believe, was my last slide, but basically it's just a summary that I wanted to say that we have, this technology, TMS, that is safe and non-invasive. And honestly, other than some discomfort that you might have in the beginning, there's really no major risk involved. It is effective. So like I stated, 70 to 80% respond. And that means that they are at least feeling 50% better than they did before. And then, though I said half here, but 1/3 to up to half of the people who respond feel like their depression is totally gone. FDA approved. So most insurances will cover costs to treat depression. Short visits, we're talking less than 30 minutes. You can go right back to work, whatever lunch break you may have taken to come in for this. Medication reduction. Most people end up reducing either reducing doses of medicine they're on, or they completely come off of them because the TMS has been that helpful and long lasting. Again, designed to be a one-time treatment for most people, so that this isn't something that we're regularly or routinely coming back to redo. And next slide. Yeah, that was last slide. So I think I saw some questions, but I will
Questions there.
Yeah.
Yes. Well, thank you so much. Great information. And I do have a couple of things. I'm going back and forth between the chat and the Q&A. Someone is asking, does Medicare pay for TMS?
Yes, I believe it does. We'd have to verify insurances, of course, but in most cases, Medicare is covering TMS treatment.
Okay. And as someone is pursuing that, do they usually get like a referral from their physician or from their psychiatrist, or how does that process start?
Yeah, so if somebody is interested in TMS, what we do is a free consultation. What we will do is go through a questionnaire and ask them specific questions relating to the condition. And once they meet those criteria, they then get a consultation with a psychiatrist. In this case, it would be Dr. Hussein, which will go through a thorough consultation and determine whether the patient is a actual candidate for the TMS treatment.
Okay, great. Thank you. And we've got a couple questions about how it might be effective with some other conditions. For example, someone's asking if it's helpful with people who are experiencing OCD.
Yes.
Disorder.
Yeah. OCD. OCD is one of the FDA approvals. Every TMS device technically isn't designed to treat OCD. But yes, OCD is one of the conditions that TMS can treat and insurances will pay for.
Okay, and how about people on the autism spectrum?
So autism spectrum is one of those on the off-label category. In children in general, TMS just it hasn't had the research. The research, unfortunately, just from fear of if it could cause some other more permanent long-term changes. But there have been a lot of subjects that TMS has studied on autistic children and more of the older children, but it's their sort of the behavioral impulsive aggression, sort of those issues, those things they do see improvements on, but not so much improvement in social cues or that other aspect of autism. They haven't really seen any improvement there.
Okay, and so kind of a follow-up question is, do patients need to be 18 years or older in order to get TMS treatment?
So Sanjoy can answer this, but basically, yes, they do for most insurances. I think that there's one or two insurances that I have come across that if you are 16 and you have a pretty good reason why a psychiatrist feels like TMS should be tried, that they might consider down to 16, but otherwise 18 and up.
Okay, thank you. And I believe you talked about it being effective with various addictions, and someone is asking, is it helpful for weight loss?
So is it helpful to lose weight? There, that's something, it's kind of where's the underlying cause of that? Is it something related to OCD, fears of, some sort of fear where it's a rigid thought? Then of course an OCD type of treatment can help. If it is related to anxiety or depression, then yes, TMS can help. If it's something more where it's this almost psychotic kind of thing where the thought is more of an irrational fear, just sort of more where it's not really kind of set in reality and more of a psychotic kind of thought that's creating that, then probably not. Fortunately can't give a clear-cut answer just because there could be a lot of reasons why the weight gain is happening in the first place. And of course, there's medical reasons as well, but it is possible that it can help with weight loss.
Okay, and I'm going to go to these questions that are dealing with treating certain concerns first, and then we'll go into some of the others.
Sure.
Someone mentions if grief is not true depression, would grief be a reason to pursue TMS or no?
Yes. So truthfully, TMS, outside of the fact that FDA's approved it for major depressive disorder, and insurance companies kind of want to see that you are really struggling with depression before they agree to pay for it. TMS can help even sort of the milder depressive symptoms. So even if it is just sadness or extended, prolonged sadness that someone is experiencing, it is possible, yes, that TMS can help you feel better. I think the question is more, will insurance pay for that? That's a different story. But no, TMS can help in a lot of areas, and even if you're not sort of in that severe sort of depressive state.
Okay. And is it effective with Parkinson's?
So that's a little outside of my area of expertise, but I did this fellowship course where basically it was kind of getting into more of the neurological conditions that TMS can treat. And Parkinson's is one where there has been a lot of promising evidence so far. I want to say it's probably the most, and if I wouldn't be surprised if there is an indication or FDA approval for it actually coming soon. But yes, Parkinson's, overall tremors, a lot of the early kind of symptoms that they experience, they have some pretty good evidence so far that it can help.
Okay. And I've got a couple questions about the development. Someone is asking how and where was TMS developed originally?
So TMS took Dr. Roy.
I'm sorry. I want you to take that question. I'm not. Yeah, go ahead.
So TMS, so it still does stem from the concept of the electroconvulsive therapy that was, again, though practiced still in certain situations, but practiced more often in the past. They wanted to see if the brain is really, if you can influence it with electricity, can we sort of perfect this, fine tune it, make it, have less side effects, some way to make it more convenient for people. Does it have to require anesthesia? Sort of all of the things that ECT, all the negatives that it had, can we, come up with another version of it? So that's where the research started. And I want to say this has been over 40 years ago where they really started looking at other ways. TMS has been used in Europe for decades longer than it has here. It just got their sort of the approval there. Their version of the FDA had it a lot earlier. And then once they realized that it's, it works, just, took about 10 to 20 years for, I think, the US to sort of pick that up. So the research is actually a lot more promising in Europe, where they've gotten stroke rehab patients moving again. I mean, there's so much going on in Europe that we're just a little behind here.
Certainly are. Certainly are.
And someone is asking what type of training is needed for a provider to administer TMS treatments.
So the actual TMS treatment itself there's state dependent and insurance dependent. Some states will allow anyone who either the vendor, the TMS manufacturer has certified, or physician has certified to do. Some states and insurances, not many, but some are a lot stricter, and they require a physician to actually do the treatment itself. So the treatment itself isn't something that requires a lot of skill or expertise. It's more of finding the patient that is indicated for TMS, and the first sort of visit where you're trying to determine how much energy that you need and where to place the magnet. So again, there are states and insurances that will even let nurse practitioners do that. At Albatross, I do it myself when it comes to the actual mapping, but that is something that does kind of depend on the state and then the insurance company as well. And I don't know if Dr. Roy has more to add.
Yeah, just to add to that, all of our staff here are formally trained on providing the TMS treatment here. So they go to formal training for them to be able to understand the theory behind why it works and how it works, and being able to administer it effectively. We're also on the lookout for any sort of adverse reactions or anything like that. So we have to be formally trained to be able to administer it.
Okay, great. Thank you. And I just have one or two last questions here. Someone is asking about the difference between this or maybe deep brain stimulation as an alternative. How do you feel about deep brain stimulation? Someone is asking.
So specifically deep brain stimulation, or is it deep TMS? I'm sorry. Is that the question?
The question says, how do you feel
deep
about
brain stimulation?
I think.
Okay, deep brain stimulation. Yeah. So deep brain stimulation is something that again it becomes a little bit more invasive. You're using you're going into the brain, and does it work? Yes, it can actually. I think if we actually go back to sort of the gold standard when it comes to a lot of these, though I mentioned a lot of side effects and problems with ECT. ECT actually was always the gold standard in terms of what will work at the end of the day. And it has shown over 90%. So if you were at a place where nothing worked, last resort ECT you knew would work. It's just that now it's, can we come up with safer alternatives? So deep brain stimulation goes back to the concept of, using actual electrical currents to stimulate the brain. So yes, DBS will work, but does it need to go to that? I would suggest trying something like TMS that is safer, outpatient, before moving into something where you're, really requiring to go into the brain.
And to answer Kathy Surf's other question, are you located in County Farm Road and Roosevelt Road? Yes, we are. We're in the corner of County Farm and Roosevelt Road. You'll see us above the Verdict restaurant. I don't know if you know where that is, but that's where we are.
Right. And I'll be sending out lots of contact information in your website and such in the follow-up email later tonight. It looks like we just have one or two other questions. Back to that training, are psychiatric residents in the U.S. generally taught TMS procedures at this point, since it's FDA approved?
So psychiatric residents, if the residency does have TMS available, a lot of the residents, I'm sure, would be able to get involved in TMS. It's again, when it comes to in residency, I suppose there's just so much that they want you to learn. So I don't know if they spend a whole lot of time on TMS, but overall, it is possible the residents can get some training in it. Yeah. I had some training, if that answers the question too, in residency.
All right. And again, I think we'll take this as the last question, but again, I'll be sending out some additional resources and information, including a lot of contact information and the Albatross websites and email addresses and all of that in an email following tonight's presentation. If you're watching the recording of this program, you can just email me at ce@wheatonlibrary.org, and I'd be happy to send those resources out to you. But like I said, one last question. Can you give us a sense of approximate cost? That's kind of tricky with
it
insurance.
Is tricky. Usually we do accept insurances. So depending on what insurance the patient has, that's how the cost is basically decided. The cost in general, if someone were to pay cash, depends on the extent at how long the treatment will last. Some people like to just do it for 15 sessions, or some people like to go all the way through the 36 sessions. Some people feel like after 15 sessions, they feel great and then no longer need it. So they'll pay based on that cost up to that time. So it all depends. It's variable. I rather talk to that person in person to be able to really convey the cost. So does that kind of answer the question?
I think that's really probably all you can say at this point. I know that it's kind of a tricky thing. We talked about how many insurance companies cover it, and someone is just asking about a specific insurance company, Blue Cross Blue Shield. I don't know if you can probably answer that.
Yes, we are in network with Blue Cross Blue Shield, and we treat Blue Cross Blue Shield patients all the time. So yes.
Okay, that's wonderful. Okay, well, and again, I think these other questions will probably be answered and people can follow up with you by going to your website or contacting you, and I'll be sending that information out later tonight. Again, if you're watching this recording and would like those contact links, just email me at ce@wheatonlibrary.org, and I'm happy to send that out to you. But thank you so much for your time, Dr. Roy and Dr. Hussain, for providing all this expertise and answering our many, many questions. We appreciate your time and all the effort that went into putting this together. So I think with that, we'll say good night. Everybody stay safe and healthy, and we hope to see you again soon. Good night.
Good night.
Bye.